Can you identify what this patient can be suffering from? As you can see, in his around his right eye there are herpes zoster ophthalmicus lesions, and in the left eye you can see there is a fleshy mass over the conjunctiva, and below it there is molluscum like lesions. So the thing in the conjunctiva can be a sarcoma or a neoplasm, and these are all the symptoms of immunodeficiency. So here we are discussing the ocular manifestations of HIV and AIDS. So it is an infection by human immunodeficiency virus which reduces the lymphocyte count, leading to opportunistic infections as well as neoplasms. Around 70% of the patients show ocular involvement, and the staging is based on CD4 count. So if the counts are less than 500, they can be infections in the eye, and if the counts are below 200, they can be all opportunistic infections inside the eye. So if you haven't subscribed to my channel, please do subscribe. How can we divide these lesions? So we can divide it into adnexal lesions inside the eye, that is ocular lesions, and neurological lesions. Okay, so coming to the adnexal lesions, we have the first one which we saw in the image, that is molluscum contagiosum. So molluscum contagiosum, it is a viral infection of the skin. It is seen in 20% of cases of HIV. It is a painless umbilicated nodular lesions which on pressing reveal waxy discharge. The treatment is with excision and curettage or cryotherapy. The other lesions include herpes zoster ophthalmicus. So it is the reactivation of latent varicella zoster virus. So this virus, that is shingles, it is located at the dorsal root ganglion of third ganglion, that is trigeminal ganglion. It manifests as a maculopapular vesicular rash, and in the image here we can see this rash has subsided, leading to scars. So these do not cross the midline. The treatment is with oral acyclovir 800 mg 500 times a day. In the immunocompromised, we might need to give the intravenous drug for 2 weeks. Kaposi sarcoma, we saw it in the left eye of the image, is a vascular neoplasm. So it is the most common anterior segment lesion in a patient of AIDS. You can see here in the image, it is located in the conjunctiva. It is a violaceous non-tender nodule. It can be there at the eyelid or in the conjunctiva. So it first involves the skin, and later it can involve gastrointestinal tract or the central nervous system. Treatment is by radiotherapy. Next, coming to the other lesions, we have conjunctival squamous cell carcinoma. So this is the third most common neoplasm associated with HIV. So it is a pinkish gelatinous growth which is located in the interpalpebral area. As you can see in the picture, there is engorged feeder vessels which supply the neoplasm. So this is a characteristic finding which you can see. The metastases are rare, and the treatment is with local excision with cryotherapy. Coming to what are the ocular manifestations per se. So the general are dry eye. It is associated with because of Zika syndrome or due to recurrent blepharitis, the patient can develop dry eye, and there is anterior uveitis. So the etiology of it can be due to, it can be a direct manifestation of the AIDS disease, or it can be due to autoimmune reaction to the disease, and it can also be due to drug induced, which is because of rifabutin. So it has toxic effect on the non-pigmented epithelium of ciliary body, which causes anterior uveitis. It can also be due to associated infections with either HZV, HSV, cytomegalovirus, and syphilis. The posterior segment manifestations include retinal microvasculitis. So in this, what happens, more than 50% of the patients show this. There are microaneurysms and intraretinal hemorrhages which are seen, and there are characteristically cotton wool spots. Multiple cotton wool spots are seen. So we can differentiate it from hypertensive retinopathy because these are very specifically located and multiple are there, and there are no vessel changes, and these are usually asymptomatic cases. We have cytomegalovirus retinitis. So the other posterior segment manifestations are due to co-recurrent infections with various viruses. So in CMV retinitis, it is most common intraocular opportunistic infection. We can see retinal necrosis, vasculitis, and there can also be a bushfire pattern. The treatment is with the help of ganciclovir, foscarnet, cidofovir, and all this. We have acute retinal necrosis. So this is due to herpes zoster virus. There is peripheral whitening of retina along with marked vitritis. It can also lead to complications like optic neuritis and retinal detachments. So this is due to varicella zoster virus and can also be due to cytomegalovirus, and the treatment is very difficult. So similarly, in the case of progressive outer retinal necrosis also, the etiology is the same, but it occurs commonly in immunocompromised patients. So there is devastating viral retinitis without vitritis. We can see whitish lesions with no hemorrhages or exudates, and there is rapid progression and very poor prognosis. Next is toxoplasma retinochoroiditis. So the manifestations in immunocompromised are different from that of normal patient. So in immunocompromised, it can be a bilateral and a multifocal disease, whereas in the immune rich patients, it can be unilateral and unifocal, and there are no pigmented scars surrounding the area of necrosis in this, and there can also be CNS involvement. Syphilis retinitis is retinitis with dense vitritis. There are chances of serious retinal detachment. The treatment is with high dose IV penicillin, so which can be given for 2 weeks. The treatment of toxoplasma retinochoroiditis is, I forgot to mention, sulfadiazine, and there are 3-drug therapy also. And we have Candida albigans endophthalmitis. So this is very rare, and usually there is history of drug abuse or indwelling central lines. These are whitish fluffy lesions, ball-like lesions in the retina. So it manifests as floaters in the eye. So the drug of choice is amphotericin B. Now coming to last but not the least, tuberculosis. So tuberculosis can coexist, that is co-infection along with AIDS. So it causes severe posterior segment inflammation and can lead to choroidal tubercles, subretinal abscess, vitritis, endophthalmitis, and panophthalmitis. And when the CD4 count is very low, it can also lead to CNS tuberculosis, tuberculous meningitis, and all. Now coming to the neurological manifestations, it can manifest as headache, retroorbital pain, and optic neuritis because of all the infections. So if you like this video, please subscribe to my channel, and thanks for watching. Bye.